With EMRs becoming more common within shared health, we wanted to review the skill set that they are able to work within. Document A06.1 brings together the procedures, medications, established infusions, and established devices that they are able to perform and maintain within their scope. As we work through A06.1, many of the lines will have Note 7 listed beside them. Note 7 at the bottom of the document states, this specific procedure or medication requires ERS approved training and verification of initial and ongoing competency. ERS reserves the right to require additional training and verification of the competency for any provider, procedure, or medication. In-person training for each of these items will be provided so that each EMR can work within the scope as listed here. Beginning with Table A, which is procedures, EMRs are able to give oxygen, titrate and use oximetry to monitor, insert OPAs and MPAs, remove a supraglottic airway obstruction without the use of McGill forceps, manage basic care of a patient with a tracheostomy, including suctioning, using the Zoll monitor as an AED, just as a PCP would. Maternal and newborn care has the same items listed as the PCP scope. For trauma and surgical, closed reduction for extrication, immobilization, or to restore perfusion, eye irrigation, management of an impaled object, and basic wound care, which includes irrigation and wound packing. Note, ECGs are not listed here, so any patient requiring cardiac monitoring would be outside of an EMR scope. As for medication administration, we will go over that now as we review Table B. Table B lists the medications that EMRs can administer and by which route they can administer them. They are Tylenol, ASA, epi from an autoinjector, intranasal glucagon, oral glucose, ibuprofen, salbutamol from an MDI, and Narcan. Narcan is one medication that isn't in a pre-dosed form. EMRs are able to drop and deliver Narcan intranasal just as a PCP, ICP, and ACP would. Before looking at Table C, we first need to read Note 5. Note 5 at the bottom of A06.1 states that for an IFT, an EMR is authorized to independently transport a patient with a medication infusion, listed in Table C, and/or medical device, listed in Table D, that has been established by another healthcare provider if all of the following requirements are met. The transfer is time sensitive and the infusion and/or device is essential to the patient's care. The EMR possesses the necessary knowledge, skill, and judgment. The infusion and/or device is wholly established, including the labeling of medication, by staff at the referring facility and is fully operational before leaving the referring facility. The EMR is not expected to adjust or titrate the medication infusion rate. The EMR is not expected to control or adjust the device. A copy of the prescriber's order, if applicable, accompanies the patient. The prescriber or an appropriate designate remains available to provide direction in the event of complication. If the EMR cannot reach the referring provider, they will obtain and follow direction from OLMS. So, and if an IFT gets dispatched, you can use this document to be sure that it is a patient they are able to manage based on these criteria using tables C and D as references. Table D lists the established medical devices EMRs are able to manage. On this list, you can see IVs are included. So if an IV is started on scene, it doesn't automatically mean the PCP or above partner will be leading the call. As long as the patient or any medication given to them can be managed within the EMR scope as listed in this document, they are able to continue with leading the call. All the information within A06.1 has been summed up here within this one-page graphic, which will be made available to all staff. Beyond A06.1 and this graphic, an EMR is able to provide a medication double check. EMRs are also able to drop medications for their partner, but the point to be emphasized is that an EMR cannot be asked to give that medication they have drawn up if it is outside of their scope. no different than a PCP drawing up meds for their ICP and ACP partners. Before a medication that any partner has drawn up is given, it is the responsibility of the provider giving that medication to ensure the 6 rights of safe medication administration are confirmed before they give that medication to the patient. As a reminder, the 6 rights are listed in document H04. If any questions arise about the scope of work that you or your partner can perform, please take a moment to review the ERS care maps in Section A or reach out to an education officer or CSL.